This is the board review lecture for plantar fasciitis and heel pain. The differential diagnosis includes the more common conditions such as proximal plantar fasciitis, distal tarsal tunnel syndrome, calcaneal stress fracture, plantar fascial rupture, or central heel pain syndrome and fat pad disorders. Less common conditions include tumors, infections, FHL tendinitis, plantar fibromatosis, and rheumatological conditions. The plantar fascia is comprised of three inelastic fibrous bands. The central band is the main component, and it's over the FDB muscle. The medial band is over the abductor hallucis muscle, and the lateral band is over the abductor digiti minimi muscle. The origin is the medial tubercle calcaneus, and the insertion is the proximal phalanges of the toes. The function of the plantar fascia is to help maintain the arch. During the second half of the stance phase, the windlass mechanism occurs. Toe dorsiflexion tightens the plantar fascia, which you see on the right. The pathophysiology is a tensile overload with degenerative and inflammatory changes. It may be associated with either planovalgus or cavus feet and plantar fascia tears. Plantar fasciitis accounts for 80% of patients with plantar heel pain. In the United States, 2 million are treated annually, and it represents 1% of all orthopedic visits. 10% of patients have a risk of developing plantar fasciitis during their lifetime, and 1/3 are affected bilaterally. Plantar fasciitis can be seen in a wide age range, usually occurring in typical middle-aged patients that are active. The onset is usually insidious with no significant event. However, some patients will have noticed the increased activity more than typical. The pain is usually one of initiation, occurring with the first steps in the morning or after prolonged sitting. This can be seen in runners, military personnel, or overweight patients. This can be an overuse injury, can be seen with pes planus or cavus, and patients with limited ankle dorsiflexion. Red flags to consider: something else besides plantar fasciitis, including burning night or rest pain or afterburn, which could represent nerve entrapment or irritation. A sudden injury can represent a fracture or a rupture, and when it occurs bilaterally at both the Achilles insertion and plantar fascia, you should think something rheumatological, such as seronegative, psoriatic, or Reiter's. The physical examination for plantar fasciitis shows pain or tenderness over the medial calcaneal tubercle, which increases with ankle and toe passage dorsiflexion. The picture on the bottom left shows the areas of maximum tenderness for the various conditions which can cause plantar medial heel pain. Associated pathology seen in plantar fasciitis can include Achilles or isolated gastroc contracture and cavus or planovalgus foot. A squeeze test can indicate a stress fracture of the calcaneus and is shown on the right side where you squeeze the calcaneus. Tenderness over the abductor hallucis muscle in the medial hindfoot can be consistent with entrapment of Baxter's nerve. Imaging for plantar fasciitis starts with radiographs. A heel spur is often seen in asymptomatic patients. An ultrasound shows thickening of the plantar fascia. An MRI is more useful to exclude other diagnoses, such as a stress fracture. However, on the bottom right, you can see an MRI consistent with plantar fasciitis, which shows bone marrow edema or partial tear. Bone scans can be indicated, but in my opinion, they have little use, and an EMG can be considered if you're concerned about nerve entrapment. Non-operative treatment of plantar fasciitis should begin with tissue-specific stretching and conditioning of both the plantar fascia and Achilles. Night splints, orthotics, anti-inflammatories, injections, immobilization, and shockwave can be considered as well. 80 to 90% of the symptoms resolve by 6 and 9 months. The resolution is usually slow. Historically, emphasis was on stretching the Achilles. However, more recent studies suggest plantar fascia stretching is more effective. In 2003, a level 1 randomized controlled trial included 82 patients with a minimum of 10-month symptom duration. The plantar fascia stretching group had significant improvement in pain, function, and satisfaction at 8 weeks versus the Achilles stretch group. The Achilles stretch group did improve, but to a significantly less degree. I find night splints to be very helpful, and it's one of my initial treatment options. It's supported by some level 2 studies, but these studies are limited by small numbers with suboptimal study design and methodology. One complaint is poor patient tolerance, which should limit its effectiveness. If a patient reports numbness, then I tell them to stop utilizing a splint. If they can't tolerate the whole entire night with a splint, then I recommend they utilize it for a couple hours before they go to sleep when they're resting, watching TV, or reading. Orthotics are frequently utilized as well. Several level 1 evidence studies show no significant benefit of custom versus over-the-counter. And if you choose an over-the-counter orthotic, I'd recommend a soft as opposed to a rigid insert. Injections are another common treatment option for plantar fasciitis. Usually it's a corticosteroid. There's level 2 evidence for short-term but not long-term benefit, and up to 10% long-term rupture risk. It's important to inject the fascia at its bone origin and not in the distal portion or a fat pad, because this can lead to fat pad atrophy. An ultrasound guidance is more accurate. PRP has been more popular recently. The conflicting results in several randomized controlled trials comparing PRP with corticosteroids. A recent meta-analysis supports evidence of better short-term outcomes over steroids and the added benefit of no risk of rupture. Cast immobilization or cam walker mobilization is another option. However, there are no high-level studies specifically evaluating these two treatment options. I prefer a cam walker. There's been description of a short leg weight-bearing cast for 2 to 3 weeks. This breaks the cycle of inflammation. If you use this technique, it's important to extend the cast distal to the toes and possibly dorsiflex the MTB joints for increased stretch. There's level 1 and 2 evidence for iontophoresis as a transient benefit. It may be less risky than a steroid shot. Phontophoresis, ice, and contrast bath have also been described. Shockwave delivers energy at interface of differing acoustic impedance. There's options which include low or high energy to reduce inflammation, create neovascularization, and alter the peripheral nerve function. Level 1 supports both high and low energy in difficult cases. It lowered eventual need for surgery from 58% to 13%, and there are many studies shown below which support shockwave. Operative treatment. An AOFAS position statement recommends a minimum of 6, preferably 12 months of non-operative treatment. There are numerous methods available with limited number of high-quality articles to guide treatment. These procedures include partial plantar fascia release, which is the most common, decompression of any nerve entrapment, removal of heel spur, and lengthening the gastrocnemius contracture. Personally, I do not remove the heel spur, and I tell my patients this preoperatively, so if they ever see an x-ray in the future, they will not be upset that the heel spur is still present. Most common operative treatment is a partial plantar fascia release. As noted, this is only a partial release involving the medial 1/3 to 50% unless there's severe cavus. The complications of an excessive release include loss of an arch and lateral midfoot pain, which is difficult to treat. It's typically performed at the proximal portion. This can be done open or endoscopically. Open plantar fascia release, the literature shows 70-95% satisfactory results. Endoscopic partial plantar fascia release mostly has level 4 evidence. If you choose this technique, the patient cannot have nerve involvement. You must avoid excessive release and injury to the adjacent nerves. A study in 2012 showed a 76% pain resolution in 49 feet over almost 50-month follow-up. There was a greater mean improvement in patients with severe and moderate symptoms. Gastroc recession can be considered in patients with an isolated gastroc contracture noted on exam. This is indicated by the positive silver skull test. A tight gastroc increases strain on the plantar fascia. The most common techniques include a Strayer, which is more distal, and a Baumann, which is more proximal. There is limited studies, mostly level 4 support. There are encouraging early results showing decreased pain and increased ankle dorsiflexion. Other causes of plantar heel pain include a calcaneal stress fracture. This is treated non-operatively with a walking boot and a soft insert for 2 to 4 weeks. The patient can wait there as tolerated. You can consider supplemental treatment with calcium and vitamin D. The bottom left X-ray shows a calcaneal stress fracture. Plantar fascia rupture usually is noted by a patient with pain and tearing sensation. There's usually a specific event or injury where a patient feels a pop or a tear. They'll notice bruising on the plantar aspect of their midfoot, seen in this picture on the right. This is treated non-operatively in a walking boot for 2 to 6 weeks. The patient then graduates to non-impact exercises and then low impact. Stretching exercises is recommended as well. The recovery may take a long time. Plantar fibromatosis is a benign tumor of the plantar fascia. Myofibroblast and collagen proliferation is noted. This is a similar process to Dupuytren's. It is bilateral in 25 to 50% of the time. Dupuytren's can occur in 25% of the patients, and some patients will notice Peyronie's. Recurrence is common after a local excision. On examination, subcutaneous thickening or nodules are noted. Treatment is usually conservative, including anti-inflammatories, orthotics, physical therapy, or corticosteroid injections. Operative treatment could include excision with or without radiation. As noted before, recurrence is common. Risk factors of recurrence includes bilateral diseases, multiple nodules, a family history of plantar fibromatosis. Prevention can include adjuvant radiation. Let's take a moment to review the tarsal tunnel anatomy, seen here on the right. This includes the tibial nerve, the postiotibial vessels. The postiotibial, FDL, and FHL tendons are deep to the flexor retinaculum. The tibial nerve branches into the medial calcaneal, medial plantar, lateral plantar. The lateral plantar first branch is also known as Baxter's nerve. You also have the medial plantar nerve and the lateral plantar nerve. The first branch of the lateral plantar nerve has a sensory component to medial calcaneal tubercle periosteum and a motor component to the quadratus plantae and abductor digiti minimi. This travels between the abductor hallucis and quadratus and then between the FDB and quadratus. This may be compressed under abductor hallucis deep fascia and commonly associated with plantar fasciitis. As noted before, it's also called Baxter's nerve and nerve to the abductor digiti minimi. Foot position can create tension on the tibial nerve. Cadaveric studies have shown increased tension during eversion, dorsiflexion, and eversion with dorsiflexion. Various etiologies of the tarsal tunnel can include space-occupying lesions. Numerous causes reported include engorged varicose veins, neuroloboma, intraneural degenerative cyst, synovial cyst, PVNS, ganglion cysts of the FDL, FHL, and subtalar joint, fractures such as displaced medial wall of the calcaneus. Congenital abnormalities include tarsal coalitions and accessory muscles. Accessory muscles included the FDL or tibiocalcaneus internus muscle. Idiopathic causes are usually distal to the abductor hallucis fascia. Clinical features of tarsal tunnel include burning or aching pain in the plantar aspect of the foot. Paresthesia and numbness can be noted. Aggravating factors include prolonged standing or walking, high heel shoes, and symptoms at the end of the day. A patient may be awakened with night pain and paresthesia. On physical examination, muscular atrophy may be noted in the intrinsics and the abductor hallucis brevis. Tinel sign can cause radiation of pain into the foot distally, into the symptomatic area, or into the calf more proximally. Nerve compression tests consist of a gentle manual pressure for 30 seconds, and symptoms are reproduced. Other conditions should be excluded, such as proximal neurologic pathology, peripheral neuropathy, multiple diffuse nerve tendinous syndrome, and CRPS. Positive findings on an EMG can include distal motor latencies of 7 milliseconds or more, prolonged sensory latencies of more than 2.3 milliseconds. Sensory is more likely to be abnormal than motor. Decreased amplitude of motor action potentials of the abductor hallucis or abductor digiti minimi. Radiographs or an MRI can be obtained. This is useful to rule out bony or soft tissue causes of tarsal tunnel, such as accessory muscle or soft tissue tumor. Conservative treatment of tarsal tunnel includes physiotherapy for deep massage to break up scar tissue, iontophoresis to control local inflammation such as tenosynovitis, stretching exercises to mobilize the nerve within the tunnel. Localized steroid and anesthetic injections can be utilized to control swelling and inflammation and as a diagnostic test. Orthotics can be indicated for patients with hindfoot malalignment. Other conservative treatments include medications such as anti-inflammatories, oral steroids, vitamin B6, tricyclic antidepressants, anti-epileptic drugs, benzodiazepines, opioids, SSRI, and Lyrica. A surgical release is indicated for people who fail conservative treatment, usually after 3 to 6 months and probably even longer. A positive EMG should be noted with reproducible physical findings. If a compressive mass such as ganglion cyst is identified, it should be removed. You can see the anatomy, once again, on the right-hand side. Outcomes for surgical release are best when you have macroscopic pathology. Traction neuritis does not respond well to surgery. A study in 1998 showed long-term results over a 10-year period of 34 feet. 72% were satisfied with release. However, there's a 30% perioperative complications. Here are 2 questions for the end of the lecture. Question 1 is a 40-year-old female presenting to a physician for initial visit with a 5-month history of plantar medial heel pain. She notices it immediately on getting out of bed in the morning, but the pain improves after a few steps. The pain is exacerbated throughout her workday to the point where she's unable to finish her work shift. The figure shows a lateral radiograph of the affected heel. Which of the following is the most appropriate initial treatment? 1, walker boot immobilization with full weight bearing for 4 weeks. 2, corticosteroid injection at the plantar fascia. 3, surgical release of 50% of the plantar fascia. 4, heel spur resection. 5, Achilles stretching exercises. The obvious answer is Achilles stretching. Question 2. For the treatment of new onset plantar fasciitis, which of the following modalities results in the highest patient satisfaction at 8 weeks of follow-up? 1, isolated Achilles stretching. 2, steroid injection. 3, shockwave. 4, plantar fascia specific stretching program. Or 5, distal tarsal tunnel decompression with partial plantar fascia release. And the answer is 4, plantar fascia specific stretching program. This was discussed earlier in our lecture, which is shown to be more beneficial than isolated Achilles tendon stretching. That's the end of the lecture, and I wish all of you the best of luck on the boards.